Speaker, Dr. Dennis Foley from Frederick Hospital, will talk on rupturing aortic aneurysm.
Thank you, Dominic. So I'm going to extend the conversation from the aorta to the visceral arteries at the end of the presentation. So, common understanding about the mortality of ruptured aortas: the immediate mortality, 50%, operative mortality, 50%. But the symptomatic or contained population may have a lower mortality rate, as you can see here, between 10 and 20%. So we've got to understand what we mean by the symptomatic and contained aneurysm. Let's take this example of a patient who's got what's called the crescent sign. And if you look, you can see there's this arc of high attenuation, which is rather curvilinear, probably representing expansion of the aneurysm, creating separation of the lining thrombus, which is filled by more recent thrombus, which forms this coagulum. You can see that's also associated with some expansion of the aorta focally where the calcium is interrupted. And that probably actually represents a leak, but it's contained. And you see the same findings down here at a slightly lower level. So that's a very important non-contrast finding. Here's a patient whose aorta shows aneurysm, and then if you look at the section down below, you can see there's an interruption of the calcium in the wall. That's also associated with a contained hematoma in the psoas muscle. So here's a non-contrast identification of a rupture which is contained, and you can see it also in the coronal. Here's a patient who's got a retroperitoneal hemorrhage, where we don't see the crescent sign or the interrupted calcium sign definitively, but you see an aneurysm. And the typical distribution of retroperitoneal hemorrhage and an aneurysm, you've got to assume that that patient's ruptured that aortic aneurysm. Again, it's a contained rupture. So in terms of definitions, a symptomatic aneurysm could be one in which there has been a wall expansion, perhaps with some contained hematoma around the aorta, and an intramural hemorrhage within the thrombus lining the aortic wall. If it's ruptured, it can be contained in the retroperitoneum, and therefore having a better prognosis. So these patients have self-separated themselves into those who have died instantaneously upon rupture versus those who have made it to a medical facility whom we're evaluating. But those who go to a medical facility who have a contained retroperitoneal hemorrhage can migrate during their observation in the hospital to a free intraperitoneal hemorrhage. So let's look at this particular case. Here's a patient who has an aneurysm, and is this a penetrating ulcer or at some point which the aneurysm is pointing? Very definitely. The patient was symptomatic, but the patient was hemodynamically stable and didn't have really any significant retroperitoneal hemorrhage, or certainly no intraperitoneal hemorrhage. But clinically, this patient collapsed some hours after this particular scan, went to the hybrid vascular room and had an emergency endovascular grafting procedure. And then when we interpreted this 24 hours later, I said to the surgeon, why is all this intraperitoneal hemorrhage present when it wasn't present preoperatively? And the answer was this patient ruptured between this study and having it repaired. So rupture with survival. And this is just air-based inside the aneurysm sac as a result of doing the angiographic procedure about a day after the intervention. Here's another example of a patient who's got a retroperitoneal contained rupture, and it's interesting that the dissection plane, as it were, corresponds to what you might consider to be the crescent sign. So this is, as it were, how the crescent sign happens. When you get this dissection, I believe, in the thrombus, which then subsequently becomes thrombosed and hyperattenuating. Notice that the angiographic study is one where we can do some planning. So you can look at the subrenal aorta, look at the characteristics of the superior neck, and look at the characteristics of the iliacs. In other words, doing angiography in patients with ruptured aortas who may be hemodynamically compromised, it's extremely important to the management of these patients and has to be done technically very well. That's just pointing out the superior neck. Not a good candidate for eval. Here's another patient who's got a contained rupture where you can see this large amount of extraluminal contrast in the retroperitoneum. But what really is important is not so much these cross-sectional images, but this. And this means that you've got to be able to generate three-dimensional images fairly quickly after these particular studies are obtained. So there's the aneurysm, there's the rupture, but here we've got a long superior neck, and the curved plane reformations allow us to look at the iliacs and see that they have good access via the iliacs to do an endovascular procedure. So having demonstrated these angiographic images, what's the essence of at least the way we do our studies? And the important feature that we utilize is to determine what the patient's flow velocity is in the aorta and make sure that the table speed does not exceed the flow velocity. And this table speed is a variable that's controlled by the detector width, pitch value, and rotation time. We do mini bolus timing, and I'll explain that in the next slide. But here is aortic arrival on the mini bolus, plus a delay time, which is 6 seconds, plus the acquisition interval, which is only 4. And the contrast injection interval equals the combination of the delay time after arrival and the acquisition time. So you can see that in this particular patient, 60 ml of contrast has been sufficient. Now that's also based on patient's weight. And as patients increase their weight, we do actually increase the iodine load, meaning there's a longer delay time between arrival and the beginning of acquisition. Just to show you the points at which we obtain arrival times, supraceliac aorta, distal external iliac artery. Here's the arrival time at time to peak from the mini bolus at 12 seconds, time to peak in the iliac at 15. You're covering 30 centimeters in 3 seconds, and therefore the flow velocity is 10 centimeters per second, and then you can set your table speed to equal that flow velocity. So proceeding on to imaging of ruptured AAAs, yes, we do use non-enhanced, and we do CT angiography, and the important features there are to do it as a planning instrument, not just a diagnostic instrument, with multiplanar reformations, 3Ds, and stent graft modeling. Some of the critical imaging information: where's the rupture site? Is it suprarenal or juxtarenal? So typical EVAR would not apply. Is it iliac rather than aortic? What's the characteristic of the superior neck? What's its diameter? What's its length? What's its angulation and orientation? Very important features. And if this patient needs a surgical procedure, what's the anatomy of the left renal vein? Because a retroaortic left renal vein can easily be torn by a surgeon rapidly trying to clamp the aorta. In terms of EVAR for ruptured abdominal aortic aneurysms, this is a study that was published from Norway, and I think it mirrors lots of those that have been published over the last 5 to 10 years. If you treat them with EVAR, even though taking those patients who are hemodynamically unstable to some degree, who have challenging anatomy, the mortality in the EVAR group, again these for the contained aneurysms, is better than the surgical group. That means that the EVAR group, of course, are self-selected as those that can basically be planned to have an EVAR. But if EVAR is done, the results tend to be better than the surgical results. Now, aneurysms in the abdominal aorta may also be suprarenal or juxtarenal. And here's an example of a patient who has a suprarenal aneurysm that you can see has expanded over a time frame of about 2 weeks and has bled. And in this particular patient, this appropriate study is a thoracoabdominal aorta. And in this particular case, we did gated thorax, non-gated abdomen pelvis, because we believe that if you have to look at the ascending aorta, which may be an important issue in patients with aneurysms, then you need a gated study so you don't have motion artifact involving the aortic valve and the coronary arteries. The improvements in CT scanner performance, I think, will lead us to be able to do both gated thorax and then non-gated abdomen pelvis with the one injection. So again, here's just the representation of the three-dimensional planning, which can be done fairly quickly as part of the pre-intervention process. In looking at those patients who have these visceral artery or visceral segment aneurysms, it's important not just to look at the aneurysm and the immediate superaneurysmal aorta, but look at the distal thoracic aorta. In this case, it is quite atherosclerotic, and this patient was treated surgically. You can see the patient's obviously ruptured. Unfortunately, the surgeon clamped across this atherosclerotic aorta, and though he had a very technically successful procedure, the patient died from mesenteric artery malperfusion due to embolization from the clamp. So pointing these things out is important. One of the things that we are going to see more of is patients who have symptomatic aneurysms of these visceral segments who are going to be treated with stent grafting, including a stent graft that extends obviously above the visceral segment, but making sure beforehand that you've cannulated and endostented the visceral arteries and subsequently support the aorta above that level with an extension cuff. So these TIMNI procedures, the proximal extension cuff of the aortobiliac endograft extends above the visceral segment, that's for support, and covered endostents are placed into the visceral abdominal arteries before this is done so that the perfusion of those important viscera is maintained. So for an acute EVAR program, as it were, the important issues are have a protocol. The protocol means that the emergency room physicians, the interventional angiographers, the surgeons have to be on the same page, that the rapid imaging and CTA analysis should be provided, and we do have technologists who are 3D techs who are on call to do this. The stent grafts have to be in stock or readily available, and here's a physician team working together, at least during the interventional side, with the radiologist here, importantly, preceding to make sure that all that information is there. Some of the other aspects of symptomatic aneurysms to consider are not just those that rupture, but those that do other things. And here's an example I'm going to show you of a patient presenting with abdominal pain and GI bleeding who is septic. And if you look at this study, you can see obviously there's an aneurysm. There's something pointing here at the aortic wall, and a few sections lower you can see the continuity of that as a tract with gas in it. And this patient had an aortoduodenal fistula, and obviously this requires an extensive surgical procedure to cure this particular issue. That's just pointing out the point and then the tract, and that was gas within the duodenum. Another interesting issue is aortocaval fistulas, which are not very common. These patients will have bruits on physical exam and have high output cardiac failure. So this is just the one case we had in our experience. A patient referred from an adjacent hospital, and this was the study that was done, very nicely showed the almost immediate fill of the inferior vena cava. And here's the aortic aneurysm. Here's a sagittal view. This patient actually was treated with an endovascular stent. And the interesting issue was that the patient had a type 2 endoleak following placement of the stent, which was drained by the fistula's connection to the inferior vena cava. So there's the inferior vena cava being filled. Here's the aortic aneurysm. There's the aneurysm in a slightly more anterior plane. So this is the anterior plane where you see that, and here's the more posterior plane where you see this. I'm just going to finish up now by describing visceral artery aneurysms. Dominic has mentioned these already, but we'll look at the celiac, not specifically the hepatic or splenic, mesenteric, gastroduodenal, pancreaticoduodenal, and renal. First of all, here's an example of a patient with a long fusiform celiac artery aneurysm. As Dominic has said, they can be secondary to median arcuate ligaments. They can be secondary to segmental arterial medial lysis. Other potential causes that do include Ehlers-Danlos syndrome, trauma, mycotic aneurysms, etc. And these can actually be found incidentally on occasion. They can present with malperfusion syndrome secondary to compression of the portal vein, for instance, or the pancreatic duct. And the important issue here is to define the anatomy. This is a subvolume MIP study that clearly shows this median arcuate ligament impression on the proximal celiac artery, and here's the celiac artery aneurysm. These can end up being dissected aneurysms as well, and the interesting association, as Dominic showed us earlier, this patient with fibrodysplastic disease of the renal artery. This is probably just fortuitously associated, and I think the aneurysm probably is due to the median arcuate ligament. Celiac aneurysms are about 4% of splenic artery aneurysms. This is some of the etiologies that we've heard of. The rupture risk relates to size, and the management can be endovascular or surgical. Here's an interesting case of a patient who's got hypertrophied gastroduodenal, pancreaticoduodenal arteries, and you can see there's an aneurysm of a pancreaticoduodenal artery. In fact, this was an incidental finding in this particular patient, but you might consider it as a differential diagnosis, one of vasculitis or pancreatitis or post-trauma. And the clue again comes looking at the median arcuate ligament compression of that celiac artery, the cause of the hypertrophied gastroduodenal and pancreaticoduodenal arteries, and the very strong association with the development of that aneurysm. So pancreaticoduodenal aneurysms, 2% of visceral artery aneurysms. Interestingly, rupture is common, 62% ruptured at the time of diagnosis. I think we may be seeing more of these incidentally now that we have CT rather than finding that they are present when they rupture. It is said that rupture risk, interestingly, unrelated to size, a strong association with the occlusive disease of the celiac artery with hypertrophied collateral circulation. So the management, either endovascular or surgical. Here's another interesting visceral artery aneurysm, a patient who had a surgical repair of a type A dissection with a ascending aortic graft and some side branch conduits. And in the survey after the procedure, here was a small aneurysm. And that aneurysm got slightly larger, and at the time that the patient was studied here, the patient actually came in through the emergency room with acute abdominal pain and hypotension and had ruptured this gastroduodenal artery aneurysm. You can see the hemoperitoneum in the abdominal cavity. Luckily enough, we had good interventional radiology, was able to very quickly embolize the feeding vessels and prevent this patient exsanguinating from a gastroduodenal artery aneurysm. That's just showing you aneurysms and the coil embolization. So GD artery aneurysms are the least common of visceral artery aneurysms, usually secondary to pancreatitis. We didn't really know the etiology in this particular patient. Here's another aneurysm. It's a superior mesenteric artery aneurysm, looks like the celiac aneurysm that we saw earlier. And to reiterate what Dominic had said earlier, these can be dissected. This is a dissected SMA aneurysm. That's the false channel, and here's the true channel, and here's the dissection in the SMA aneurysm. Sometimes these aneurysms occur more distally in the mesenteric artery rather than involving their origin. These symptoms can be due to expansion or bleeding, or can be due to dissection and ischemia. Etiology, as with the celiac aneurysms, same types of disease processes. Intervention is recommended when these aneurysms are greater than 3 centimeters, if they become thrombosed, or they result in a symptomatic dissection. Finally, Ehlers-Danlos syndrome, which has been mentioned. This was a case in our practice experience of a patient who'd already had coil embolization of a common hepatic artery aneurysm, had had a splenectomy for splenic artery aneurysm, has multiple renal artery aneurysms, and has iliac artery aneurysms. And the patient presented with acute onset of lower abdominal pain. We saw the dissections of the external iliac artery, at least on the right, and then subsequently on the left. What actually caused this patient's presentation was perforation of the sigmoid colon, an association with Ehlers-Danlos syndrome. So to finish up, patients may have symptomatic aneurysmal disease, but sometimes they can present due to the complication of the systemic disease process, in this case, a sigmoid colon perforation. So in summary, for symptomatic abdominal aneurysms, we've been through the anatomic location, the aorta obviously being the major issue in terms of patient morbidity and mortality, the clinical presentation, and then I've emphasized the CT angiography. I think technique is important, patient physiological support during the procedure, appropriate anatomic coverage, and then the availability of 2D and 3D image processing to do it rapidly and correctly prior to these patients being treated. Thank you.
All right, thanks. Thanks, Dan. That was a great and comprehensive overview. We don't see this very often, the symptomatic ones. And so then it's a great pleasure as the next speaker to introduce Ian Kirkpatrick from the University of Manitoba, who will talk to us about mesenteric ischemia. Yeah.
Thanks very much, Dominic, and good morning, everybody. So I'm going to be speaking about acute mesenteric ischemia, and as you've seen, I have nothing to disclose. I'm going to talk first about the epidemiology of acute mesenteric ischemia, then discuss the pathologic basis of the imaging findings, and we'll look at the diagnostic performance of CT in the literature. Then we're going to deep dive into the individual CT signs that you can see in acute mesenteric ischemia, and then finish off by putting them all together and talk about how you actually make an accurate diagnosis. About 30 to 40% of cases of acute mesenteric ischemia are related to arterial emboli, as you can see here, shown by the arrows on this catheter angiogram. A further 20 to 30% are related to primary arterial thrombosis, as you can see here on this lateral aortogram. Another 20 to 30% of cases are related to low flow or non-occlusive ischemia, and here we have a patient who's in the reperfusion phase of non-occlusive ischemia. We'll talk about that more in a minute, where they're demonstrating mild bowel wall thickening and paradoxically hyperenhancement. And then finally, 5 to 10% of cases are related to mesenteric vein thrombosis, and here the SMV is thrombosed, shown by the arrow. So what happens in each of these conditions? Well, we're going to talk about inflow ischemia first. So be it emboli or primary thrombosis or low flow, if you block the flow to a loop of bowel, two things happen initially. The bowel enhances less and it dilates because of an ischemic ileus. You'll note that at this point, bowel wall thickening is not really a predominant finding. Now, as the ischemia progresses and becomes transmural, mesenteric edema and ascites can develop. Eventually, necrosis will set in, and as the mucosa breaks down, pneumatosis develops. This can lead to mesenteric venous gas and then finally perforation. Now, if we manage to reverse the process prior to necrosis happening, we enter what's called the reperfusion phase I alluded to earlier, and here the bowel wall starts to thicken, it's edematous, and it's starved for blood. Think of it as starved for iodine, so you can actually see, paradoxically, hyperenhancement and mucosal hyperenhancement. Okay, let's go back to our normal bowel loop, and this time look at venous obstruction. So if we occlude venous outflow, here bowel wall thickening is a predominant finding because there's congestion at play. As long as there's some venous outflow, it is not at all uncommon to see hyperenhancement in these cases, but if the venous outflow is significantly obstructed, then of course inflow will be affected and you will see hypoenhancement. Okay, well, if we look at the literature, these are the major papers done in about the last 15 years where prospective clinical trials were performed. And if we look at the last 4 papers, you can see that around 2003 there was a significant jump in the sensitivity of CT for the diagnosis. This is related to 2 factors. First, all the papers performed after this point specifically looked at patients with the clinical suspicion of acute mesenteric ischemia. And because they were focusing their efforts on these patients, they actually did a different test in these patients. They did a biphasic study where not only a portal phase exam was performed, but also a CT angiogram. And it's felt that the CTA is probably the reason why the sensitivity had a 15 to 20% jump around this time. The clinical criteria used in all of these papers was essentially the same: the classic pain out of proportion to physical findings, biochemical evidence of ischemia in the setting of abdominal pain, or abdominal pain with risk factors for ischemia, such as prior ischemia, atrial fib, hypercoagulable state, or clinical hypoperfusion or non-occlusive mesenteric ischemia suspected. All of the papers used essentially the same CT protocol. So a biphasic scan was done. Water was given as oral contrast because you don't want water affecting your 3D reformation, or you don't want oral contrast, a positive contrast agent, affecting your 3D reformations. And water also allows you to assess mucosal enhancement better. IV contrast was given at high flow rates, and thin section overlapping arterial phase images were reconstructed, as well as thicker portal phase images. Okay, let's look at the individual CT signs that we see. So some of the more common signs and some of the earlier signs are bowel dilatation, mesenteric stranding, and ascites, but unfortunately they're nonspecific. They're seen in so many acute abdominal conditions that we can't really use them to make a specific diagnosis. This does not mean that they're useless. They can draw our eye to certain parts of the scan and certain loops of bowel where perhaps we will be fortunate enough to see another more specific finding elsewhere. Mucosal enhancement, similarly, is just seen in too many infectious or inflammatory conditions to be specific. Bowel wall thickening, I said earlier, in the inflow types generally is not a predominant finding. When it's seen, it's usually mild and less than a centimeter. Here's an MRI showing some mild bowel wall thickening, shown by the arrow, with a little bit of free fluid nearby, shown by the arrowhead. But the exception is when there's venous thrombosis. And here, it is not that uncommon to have very pronounced bowel wall thickening. In fact, it can be greater than 1 centimeter, and in this case, the arrow shows SMV thrombosis. Now, moving into the more specific findings. The first of these, and one of the earlier ones, is bowel wall hypoenhancement. It's very specific, but it's one that can be difficult to identify. And the problem is that if the bowel wall is not thickened, it can be very difficult to evaluate. So in this particular case, you can see that over here we have several loops identified by arrows that are hypoenhancing, but we're really saying that because we have some nice normally enhancing loops on this side shown by the arrowhead that are enhancing well, and the patient is serving as their own internal control. If we did not have those normal loops on the right, it might be difficult looking at this to really feel that you're getting a good appreciation of what the bowel wall is doing. So I would recommend in any patient where you're looking at mesenteric ischemia, always try and identify some normal enhancing bowel loops that you feel confident about, and then use that as the internal control. In this second patient, we're fortunate that there's some mesenteric edema. So while that in itself is not specific, it leads us to several loops like these here, shown by the arrows, that are hypoenhancing relative to these normal loops on the other side, shown by the arrowheads. Solid organ infarction, of course, can occur even if you don't have acute mesenteric ischemia, but in this particular patient population where there's clinical suspicion of AMI, it is statistically a highly specific finding and usually indicative of acute bowel ischemia. Similarly, if you see mesenteric or portal vein thrombosis, in this particular patient population, statistically, the person probably does have acute mesenteric ischemia if there's clinical suspicion. Here again, the SMV is thrombosed. Pneumatosis intestinalis, likewise, is highly specific in this group. In this case, in the same patient, we have the bubbly form of pneumatosis shown by the arrows and the curvilinear form shown by the arrowheads, and much has been written about the morphology of pneumatosis and whether or not the bubbly form is more related to benign causes, curvilinear more associated with ischemia, and that is probably true, but we know now from some very good studies that both can actually be seen in either situation, and it's not the morphology that is the most important, it's whether or not the lactate is elevated and whether or not the patient is symptomatic and has clinical suspicion of mesenteric ischemia. So these are the things you need to ask if you see pneumatosis in the bowel wall. You have to watch out for the pitfall of pseudopneumatosis, and that's when you get a few little bubbles of gas trapped by stool against the bowel wall. It's not real pneumatosis, and the hallmark finding here is that the bubbles don't rise above the air fluid level. Mesenteric or portal venous gas can actually occur in any transmural bowel process. So, for example, you could see it in Crohn's disease, but if you have a set of patients where you're clinically suspicious of acute mesenteric ischemia and you see it, it is also one of these highly specific findings. Free air is, of course, not specific for ischemia, it's just specific for perforation. But if you see it, your job is pretty much done. The patient's likely going to go to the OR. In this case, the patient has pneumatosis, shown by the arrow, air dissecting through the mesentery that you can see by the arrowhead, and then the curved arrow is, of course, frank free air. Non-occlusive ischemia is a bit of its own separate beast, and here we're looking at the findings of shock abdomen. Now, if you think about these patients for a moment, we are usually not scanning them when they're acutely hypotensive and unstable. By the time they get to the CT scanner, they typically have had some resuscitation. So we're actually typically scanning them in the reperfusion phase. And it's important to bear this in mind because this is why paradoxically you may see bowel hyperenhancement in these patients. The bowel wall may actually be thickened, again, because of reperfusion. The IVC may be flattened, or it may not be because the patient may have received volume before they got to your scanner, although if the patient had significant hypotension, often the arterial vasospasm does persist for longer. You may see gallbladder wall edema or mucosal hyperenhancement of the gallbladder, peripancreatic fluid, the adrenals may be hyperenhancing, and the solid organs may be perfusing heterogeneously or, frankly, infarcted. This patient is a shock abdomen case who had been resuscitated. They have diffuse gastric bowel wall thickening, and you'll see it is actually hyperenhancing. Note also that the arrows are showing that the adrenals are hyperenhancing as well. The CT angiogram has really been key in allowing us to diagnose more cases than we ever did before. It's, of course, vital to look at the source images, but it can be very difficult to appreciate the small branch vessels on the source images, so we need more than that. We use maximum intensity projection reformations, volume-rendered images like the one shown here, showing some arterial emboli, and also curved planar reformations. In this case of arterial emboli, you can see that one of them is shown nicely on the source image, but we're still fairly proximal here, and once the vessels get smaller, it's really difficult to see them on the source data set. On the MIP, however, you can see beautifully the branching of the SMA arcade and get a lot better feel for what the small vessels are doing. But there is a potential pitfall with MIPS. In a MIP, you're basically taking a volume and projecting to the front the brightest pixel that's in a vector that's going through the volume. So if you have a little clot and it's not completely occlusive and there's some contrast on either side of it, you're going to project the contrast to the front and you could potentially obscure that clot. You have to be very conscious of that, and you can't just look at very thick section MIPs purely to make your diagnosis. So what I like to do is look at thick section MIPs to get a grand overview of the vasculature, but then thin them out and actually collapse them all the way down to just thin section coronal reformations and slide through, and use a little bit of both to avoid that pitfall. If you see something in the proximal vessel, curved planar reformations are very nice for actually estimating an accurate percent stenosis. So here, if we have a stenosis in the proximal SMA, most software packages will allow you to move along an automated center line and acquire a double oblique reformation through there to get an accurate percent stenosis. So I like to do sort of an integrated interpretation technique where I'm at the workstation myself, thickening and thinning out the slab. That way I'm not going to fall prey to these pitfalls and dial away pathology. I like to spin the slab around, take a look at the lateral aortogram view in particular to look for any proximal disease, and if there is something there, then I'll drop a curved planar reformation down it to estimate a degree stenosis. What we're actually looking for on the CTA are vascular occlusions, be them thrombotic or embolic, a significant stenosis, and really for these cases, we're talking about a stenosis of greater than 75%, or findings of non-occlusive ischemia. And those are an SMA diameter of less than or equal to 4 millimeters, impaired filling of mesenteric branches, narrowing of the SMA branch origins, or spasm or beating of the mesenteric arcade. The latter two can be a little tricky to pick up on CTA if you're not used to looking at a lot of them. They're more hallmark cath angio findings, but they are certainly ones that I have seen in my experience. SMA emboli can be shown in a number of different techniques. It doesn't really matter what you use. I personally reserve volume rendered images for showing clinicians, but as you can see, MIPS show things quite nicely if you just want to display for somebody where the actual occlusions are. This is a nice case of an SMA embolus that was pre and post embolectomy, and you can see that it opened up nicely after the embolectomy, and I love this case because at presentation you can see the bowel was diffusely hypoenhancing, but following the embolectomy this is a classic example of reperfusion where the bowel has thickened now and it is hyperenhancing. Two patients with non-occlusive ischemia. You can see in this patient there's a significant attenuation of the branches of the SMA. It's a little bit irregular, it's spasmed. Look at the celiac, it's in complete spasm. This patient over here has an SMA that's 1 millimeter, extremely diminutive, significant spasm. And in fact, the minimum intensity projection reformation that we made over here shows extensive air within mesenteric venules. Of course, the CT angios are also good for diagnosing more esoteric forms of ischemia. So in this patient, they had a huge IMA to IMV fistula that was resulting in Steele phenomenon. And this is a patient that, harkening back to our first talk here, had multiple mesenteric vascular dissections and just had an acute one that was finally the straw that broke the camel's back. So let's talk now how we put all of these signs together to actually make an accurate diagnosis. If we go back to those latter four papers that I was talking about, it turns out that they all actually ended up using pretty similar diagnostic criteria to actually diagnose ischemia. So in the patient population where there's clinical suspicion of acute mesenteric ischemia, because that's all we can say because that's the patient populations that were targeted by these studies, if you do a CT and it shows pneumatosis, mesenteric or portal venous gas, SMA occlusion, mesenteric embolism, or celiac and IMA occlusion with a significant SMA stenosis greater than 75%, or CT angiographic findings of non-occlusive ischemia, any one of these is actually enough to make an accurate diagnosis. Alternatively, if you have any bowel wall thickening plus any one of hypoenhancement, solid organ or infarction, or venous thrombosis, you can accurately make a diagnosis. Now, I know some of you are thinking, well, wait a minute. He just told me a few slides ago that these are all fairly specific findings. Why are we combining things and making things overly complex? And there is a method to the madness here. So statistically, if you think about it, you can have patients with solid organ infarcts that are chronic or venous thrombosis that is chronic, and maybe because they had that history, they might fall into the suspected clinically acute mesenteric ischemia patient population. By tying these to bowel wall thickening, you're basically obtaining evidence that these are actually having an impact on the bowel. So by doing that, you're actually preventing a small number of false positives. Similarly, hypoenhancement is tied to bowel wall thickening because it just can be difficult to diagnose. I showed you a couple cases earlier where the bowel wall was not thickened at all, and if anything, was very difficult to evaluate. We were able to assess it because we actually looked at some normal bowel that we saw elsewhere. And if you don't have that normal bowel to compare to, and you know that this patient has a strong clinical suspicion of ischemia from the ED, you might be prone to overcall ischemia if the bowel wall is extremely thin. By tying this to even just a little bowel wall thickening, you avoid those false positive cases. Now, that having been said, I would say if you're fairly familiar and comfortable with these types of cases and you're convinced that hypoenhancement is there, it is actually a very good finding and one of the earlier findings, and it probably is enough to make the call, but those papers actually ended up linking it to bowel wall thickening. I just want to touch on this one paper from 2009 very briefly. It was interesting because they made the diagnosis only with the CT angiogram. There were some issues with this paper. About a third of their cases had no confirmation, and there were no cases of venous ischemia, so it might not necessarily be indicative of real-life day-to-day practice, but they did exceptionally well with the cases they had just by using the CTA, and I think this shows the power of the CT angiogram. And it tells us that we can't just acquire the CTA and slide through it in the source data set or have our techs do a big thick slab MIP and one curved planar reformation through the SMA. We have to take the time to look at it and interrogate it because they were finding small little branch emboli, and if you don't take the time to sit at the workstation yourself and get comfortable, it is possible you may miss some of these findings. Non-occlusive ischemia, similarly, one little comment. If you look at the radiology literature, these cases are, if anything, a bit underrepresented in our literature relative to the pathology literature. And there is a good reason for this. If you think that, say, you're an intensivist, you've got a patient on your ICU who's hypotensive septic, you've given them volume, you're giving them high doses of norepinephrine, and now their lactate's going up, they've got abdominal pain, this is not a diagnostic dilemma. You know they've got ischemia. In fact, you're probably causing it with the norepinephrine. So the patient doesn't need a CT, and we, in fact, don't see a lot of these patients. I think we probably are seeing the worst of the worst, the ones where they're considering surgical intervention. The reason I mention this is that probably when you're looking at this specific patient population, the sensitivity and specificity reflected in the literature by those papers I showed you may not, in fact, translate directly to the non-occlusive ischemia group. One last word about MRI. Of course, it can be tough in these patients because of motion or bowel gas, and small amounts of air, like pneumatosis or free air, can be more difficult to see, but it does offer some advantages. So there's fewer contraindications to intravenous contrast, and we can get some vascular information, particularly venous information, without any contrast, which is very helpful if you're worried about venous thrombosis. We've had a lot of luck using 3T scanning with half-dose macrocyclic agents in patients with some renal insufficiency. And then also there's a lot of non-contrast MRV techniques. I find the BSSFP sequences very robust, good signal, and they're relatively motion resistant in this group. You can use flow-sensitive gradient echo techniques as well. There is a theoretical risk with the BSSFP sequences of having a clot that's iso-intense to the blood in the vein. I've personally never seen it in the abdomen, but certainly in the literature it has been described. Here we have a case of SMV thrombosis shown by the arrow, and then on the other side, tumor thrombus in the renal vein. And you can see the beautiful uniform high signal in the patent IVC shown by the arrowhead here. So to conclude then, hopefully I've convinced you that a biphasic scan with CT angiography is the diagnostic test of choice in these patients. And I want to stress that the CTA interpretation is key and probably responsible for that 15 to 20% increase in sensitivity that we've seen in recent years. The clinical context is also vital because if you don't know that there's the clinical suspicion of acute mesenteric ischemia, you're not going to do the best test for these patients, which is the inclusion of a CT angiogram. Finally, just a reminder that the more specific signs that we want to look for are any of the CTA abnormalities, pneumatosis, mesenteric and portal vein thrombosis or gas, infarcts, and bowel wall hypoenhancement. And with that, I thank you all very much.
Thank you very much. Thank you. That's a great overview of a complex topic. Thank you. So as the last speaker of this acute abdominal vascular disease session will be Jorge Soto, who will talk to us about another common abdominal vascular problem, which is GI bleeds.
Thanks, Dominic, and thanks for inviting me to join the group. So what we will cover during these 22 or 23 minutes is some general concepts about the clinical importance of gastrointestinal bleeding, how patients present clinically based on the location of the bleed, the various etiologies, again, deciding on where the patient is bleeding from. Specifically, I will discuss how we use CT angiography in this very important clinical condition, how CT has been incorporated increasingly into the acute care of these patients, and I will finish with some pitfalls in the imaging diagnosis. So obviously it is a very common condition. Up to about 400,000 people are hospitalized in this country every year, and the cost may go up to $4 billion as shown here on the slide. The mortality is a little higher for patients who present with upper bleeds, and it's mostly because of the more severe comorbidities these patients tend to have. About 10% for upper bleeders and about 4 to 5% for lower GI bleeders, which is more common in elderly individuals. And as I said already, the majority of the deaths are caused by exacerbation of pre-existing comorbid conditions. The hemodynamic consequences of an acute GI bleed vary depending on the magnitude of the bleed itself. If it is less than 100 cc's per day, typically patients will present with chronic iron deficiency anemia and will not come to the emergency room. As the magnitude increases up to about half a liter per day, patients then become tachycardic and develop postural hypotension. More than 15% volume blood loss can lead to shock, hypovolemic shock. And a very important point for us imagers to remember is that the vast majority of these patients who present to the ED with acute GI bleed will stop bleeding spontaneously, and we'll never see them in our imaging suites. As I've been saying, traditionally and arbitrarily, really, the bleeds have been divided into the upper causes and the lower causes based on whether they occur proximal or distal to the ligament of Treitz. Upper bleeds are responsible for about 2/3 of all the cases, and about 1/3 represent the lower GI bleeders. The clinical presentation of the upper bleeders more commonly will be with hematemesis and blood present in the contents of the aspiratory nasogastric tube, whereas patients with lower bleeds typically will present with hematochezia or a bright red blood per rectum. Either patients who have upper or lower bleeds can have melena, tar, or maroon tinged feces. But another important clinical point to keep in mind is that this clinical localization is not always accurate, because the presence of intraluminal blood, especially if it's a large amount, increases peristalsis to the point that a patient, for example, with a bleeding duodenal ulcer may present exclusively with hematochezia, and I'll show you one example of that situation. The causes have not really changed a lot over the last few years. Ulcer disease is still the most common cause of upper GI bleeds, followed by variceal bleeding, gastritis, and the others shown on the slide. And again, as I said initially, about 3/4 of these patients will stop bleeding spontaneously without any direct intervention. Lower GI bleeds, the most common causes are diverticular disease, angiodysplasia, and then tumors, hemorrhoids, and others which are much less common. And again, the vast majority will stop bleeding spontaneously without the need for any direct intervention. So how are these patients imaged when in fact the need for an imaging test is required? Traditionally, radionuclide imaging has been the first test performed, especially in lower bleeders, not so much for upper GI bleeders, and it is, and we all know, a useful screening test prior to intervention or surgery. Catheter angiography as the first test is reserved only for patients who present with massive bleeds and in whom the cause is predicted, or there's a good reason to know what the cause and the location of the bleed may be based on the pre-existing conditions the patient may have. Endoscopy is still the first test used for upper bleeders, not so much for lower bleeders for reasons that we will discuss in detail. And then CT angiography, of course, is the test that has been growing in use, and we tend to use mostly for lower GI bleeders as well. So I will just describe briefly how each one of these tests fall into the clinical practice with the merits and some deficiencies. Radionuclide imaging, typically done with tagged red blood cells, is a very sensitive examination because it detects bleeds as small as 0.04 cc's per minute. And in this clinical situation, acute GI bleeds, the sensitivity reaches about 95%. The major advantages is that it is a very sensitive test, therefore it's very good for detection. Another important key point is that we can image patients over prolonged periods of time, which of course we cannot do with CT angiography or angiography. But the major disadvantage, and I think we've all experienced this, is that it doesn't really provide much detail about the localization and the specific cause of the bleed. The availability of nuclear scintigraphy in the emergency setting off hours is variable across the world, and it is a relatively time-consuming examination. Catheter angiography is 10 times less sensitive than nuclear scintigraphy, so the bleed has to be 0.5 cc's per minute in order to be detected with catheter angiography. And in that setting, the sensitivity, of course, will be less than nuclear scintigraphy for the same reasons. These provocative measures that were so popular in the past are really no longer used. Routinely, they have a good number of complications, and with now having CT angiography, I think that has replaced the need for these more advanced procedures with angiography. What we look for in angiography, as we do with CT, is extravasation of contrast, pseudoaneurysms, AV fistulas, and hyperemia in the affected loop of bowel. However, with angiography, it is unlikely that we will be able to diagnose the specific cause of the bleed unless we see changes in the vessels themselves, such as some that have been shown already this morning. But it is the main non-surgical procedure used for effectively treating many of the patients who present especially with lower GI bleeds, and in some patients in whom endoscopy is not successful in treating the bleed in the emergency setting. Endoscopy has been the first-line test, especially upper endoscopy in upper bleeders. Colonoscopy has some limitations that I will emphasize. The main advantage of endoscopy, of course, is that it can be used to treat patients, again, especially in upper bleeders with variceal bleedings, for example. It localizes accurately the site of the bleed, characterizes the site and the cause in upper GI tract bleeds in up to about 90 to 95% of the patients. With endoscopy, one cannot really reach consistently the distal duodenum and especially the small bowel. And colonoscopy in patients with lower bleeds has the major limitation of requiring a bowel prep that, in the best case scenario, can be of 3 to 4 hours, which is really impractical in this emergency setting. And even if the patient does undergo that 3 to 4 hour preparation, it has very limited ability to identify the specific source and even the location of the bleed, which can be done in only about 20 to 30% based on the available literature. So that leads us into the discussion of why and how we're using CT and CT angiography in particular. The advantages of CT in this setting are very obvious to all of us. It's a fast technique. It's readily available in most of our ERs, very high spatial resolution with the newer scanners. And with the isotropic voxels that are now routine, we can generate very easily and almost immediately after interpreting the images the 3D reformations that are necessary for planning therapy, be it for the surgeons or the interventional radiologists. So for all these reasons, it is a very useful tool, and we use it every day in the ER for a variety of emergency abdominal conditions. Another important point is that it has been shown in vitro that the sensitivity for detecting bleeds is actually higher than catheter angiography unless it's done supraselectively, and it's about twice as sensitive as catheter angiography, which is really not surprising considering the very high spatial resolution that we can now achieve with CT. So how do we do CT in this setting? We use a triple phase CT, and I will show you multiple examples without oral contrast. We start with a non-contrast, low radiation dose series, followed by an injection of a high volume of contrast material with the highest iodine content possible. We use 370 in Europe and other countries. 400 milligrams of iodine per milliliter is available at a very fast rate, always followed, of course, by a saline chaser. And then after the non-contrast phase, we acquire two phases. The first one being an arterial phase. We prefer using bolus triggering techniques timed to the arrival or when the enhancement reaches 150 Hansfield units in the abdominal aorta, but we don't start the acquisition at that point, but wait 10, 15, or up to 20 seconds because we're not really so much interested in the vessels themselves, but what's happening in the lumen of the valve. We want to give contrast a little bit of time to accumulate in the lumen of the affected loop of valve. And then we finish with a third acquisition, which can be a venous, or more often we use a slightly delayed phase at about 3 minutes to see some changes that can be important in making the definitive diagnoses. So what do we look for? Again, as we do with angiography, signs of active bleeding, which we define as the presence of extravascular, in this case endoluminal, accumulation of contrast-enhanced blood on the arterial phase, which is not present or is larger than what we see on the non-contrast phase. And that pool of contrast, as I will show you, grows into the later phase. And of course, the more significant the bleed, the larger that the pool will become into those more later phases. And if we do find a bleed, we immediately generate, especially MIP reformations, thin slabs, as Ian was showing, to help guide the surgeons and especially the vascular, the interventional radiologists who are called in to perform definitive therapy in many of these patients. So I'll now show you multiple examples of the different causes of bleeds and how we use the three phases to make the diagnosis. Here's a typical example of someone who presents with a moderate hematochezia, non-contrast phase, low radiation dose, multiple diverticular, arterial phase, shows a small blush of contrast arising from a diverticulum, grows into the portal venous phase. In this patient, we detected the exact location, the magnitude of the bleed, and as occurs in most of these patients, no definitive therapy was necessary because this bleed stopped spontaneously. Another patient with a more significant bleed, notice that already there's a lot of clot in the colon. In the arterial phase, there's a blush arising from a diverticulum on the medial side of the cecum. There is already contrast pooling dependently in the colon. Into the delayed phase, the blush is not only larger but has progressed distally. That is telling us how significant this bleed is, despite the patient probably being hypotensive in the CT scanner, was immediately taken to angiography and embolized, and this was the definitive therapy for this particular patient. Another more older patient, 88 years old, with a massive bleed arising from a diverticulum in the left side of the colon. Here we have non-contrast arterial and portal venous phase images. The blush has grown throughout the three phases, and because of the hemodynamic instability, decision was made to operate on the patient, and the patient did survive this massive bleed. Angiodysplasia is the second most common cause of lower GI bleeds. It's about 25% of people, individuals older than 60 years old, will have foci of angiodysplasia in the colon, and pathologically it's dilated venules and arterioles with loss of the capillary sphincter function between the two with AV shunting. The vast majority of asymptomatic, when they do present with symptoms, most of the patients will have chronic, not very significant blood loss with anemia. Occasionally, it will present with a massive bleed that brings a patient to the emergency room. So what we look for on CT and CT angiography, here we have two phases, arterial phase, portal venous phase. Notice that there's an early draining vein, which is the most important or the most easily seen finding on CT, but there's also abnormal accumulation of contrast within the wall of the cecum. This is the focus of angiodysplasia, which causes AV shunting and early venous filling. The sensitivity of CT when looking for these two findings is about 70% based on this paper from a few years ago in the AJR. Now, this is a patient who presented with a significant bleed with hematochezia to the ER. Non-contrast arterial phase, portal venous phase images show the blush of contrast, which is not present on the non-contrast phase, grows into the portal venous phase, and there's a dilated early filling of the vein draining that segment of the colon. So in this patient, we made the specific diagnosis of the cause. Angiodysplasia seen very well also in the MIP image and the blush of contrast, the patient then was taken to angiography for therapy. Another patient, massive bleed, 83 years old, non-contrast, arterial portal venous phase images, blush of contrast, not seen in the non-contrast phase that grows into a portal venous phase. No specific cause seen, but notice that despite the age of this patient, there's no significant articular disease. With that in mind, statistically, the most likely cause will be angiodysplasia. The patient was taken to a hemicolectomy, and a focus of angiodysplasia was found. The third most common cause is bleeding tumors presenting with acute bleeds. I'll show you a few examples. This is a GIST tumor with a very significant bleed, arterial phase, portal venous phase. Notice there is a polypid intraluminal mass surrounded by a blush of contrast. This patient was immediately taken to laparotomy and that segment of bowel resected. Another patient that we had a few years ago had a history of an ablated renal cell carcinoma that had recurred, as shown here in the slide on the right, presented to the emergency room with a hematochezia. The CT angiogram showed a blush of intraluminal contrast in a loop of small bowel, operated on, and it was found to be a metastasis from this recurrent renal cell carcinoma. Other more infrequent conditions that one can see, this was a very sick patient with lupus vasculitis who presented with bleeding. We predicted that the cause of the bleed was likely the vasculitis itself. Still, because of the risk of doing angiography in this particular patient, we preferred to do a CTA, localize, and determine whether the patient was bleeding acutely at that time. And here we have the CTA, the portal venous phase. Clearly, there's a very significant blush of contrast. We provided the map for the interventionalist to come in and do a selective angiogram, as shown here, and the patient was subsequently embolized and treated. Other less common causes in our experience, this patient has pre-existent wall thickening, as you see here, ischemic in nature, non-contrast, arterial and portal venous phase, showing a blush of contrast arising from this loop of right colon, and the patient at this point was taken to the operating room, resected, and was found to have an ischemic loop of colon or segment of colon that had undergone necrosis and was bleeding. This is another patient that we had a few years ago, was still in the hospital after undergoing a hemicolectomy and anastomosis, developed hematochezia. We brought the patient to CT, arterial phase, portal venous phase. You see the blush of intraluminal contrast accumulating very close to the site of the anastomosis. With this, the patient was taken to angiography, and the site was confirmed, and this artery was embolized and the bleeding was successfully treated. This is something that we don't see frequently, thankfully. This is a very dramatic presentation. I don't know if you've seen any patient with an aortoenteric fistula. You see the clips here of the prior aortic repair, presented with hematemesis and hematochezia. We're taken to the CT, immediately rushed to the OR, and in fact this patient did survive this terrible complication of graft repairs. I mentioned initially that one has to be careful with a clinical presentation. Notice this patient on the non-contrast phase, there is clot in the rectum, but the cause of the bleed is coming from the stomach. This patient had a gastric ulcer causing a massive bleed, no hematemesis, presenting only with hematochezia. And notice that in the delayed phase, all of this is blood, and the blush has mixed in with a pre-existent clot in the gastric lumen. So how do we use CT angiography for these patients? The main benefit, as I showed you, is that we localize the bleeding site, direct therapy, provide a vascular map for angiography and embolization, assist in determining the best endoscopic approach if it's decided that that's what the patient needs. But more importantly is that almost without a question, in the majority of institutions, CT and CT angiography is a much more available test than nuclear scintigraphy. This is the most recent paper, a meta-analysis on this topic, 22 studies, total of 672 patients, of course, variations in technique being a meta-analysis, CT scanner generations, but the sensitivity is 85%, which is very good when one considers that some of these studies are as old as 10 or 15 years. Two more review type papers from this year. This is from a Spanish group that I collaborated with a few years ago, radiographics. And another one, this is from from Baltimore, from Johns Hopkins, AJR, and these two papers, I just want to draw your attention to them because they emphasize the technique and have multiple examples of how we use CT angiography in these patients. But the largest prospective series is this one from last year in radiology. Again, that Spanish group that evaluated 47 patients prospectively, all with CT and CT angiography and a standard of reference being colonoscopy or surgery or angiography or a combination of those three. Sensitivity in this very recent paper with up-to-date technique, 100% for detecting active bleeding. A few pitfalls that I want to finish with for the talk. High-density intraluminal contests can be difficult to distinguish from acute bleeds. Hemorrhage, of course, can be intermittent, so a patient may be bleeding and have a negative CT angiography, and in those cases, we recommend doing nuclear scintigraphy if the patient starts rebleeding. And the clue in those patients who do have a prior bleed is that there will be clot in the lumen of the bowel. So I want to emphasize how important it is to do the three phases. Here we have CT angiography and portovenous phase. There is high density material in the rectum, but it's the non-contrast phase that tells us that it's pre-existing. This patient is not actively bleeding and very likely can be treated or admitted, observed, prepped for colonoscopy, but no intervention is necessary at this point. Non-contrast phase, portovenous phase, there seems to be some high-density material, but it's really the arterial phase that tells us that the patient is bleeding from the rectum, and this was proven to be an ischemic ulcer. And another patient, non-contrast CT angiography phases, there appears to be some subtle high-density material in the colon, but it's the portovenous phase a little later that shows us that without a question the patient is bleeding from that side of the colon. So if the bleed is of a smaller magnitude, it may be seen only or be seen better only in the more delayed phases, such as this case. And finally, you may have patients such as this one with a large amount of clot in the rectum and the sigmoid, but it's all pre-existent. This patient had stopped bleeding before was taken to CT, and this is the type of patient that can be admitted, observed, and prepared for whatever endoscopy is necessary, but not on an emergent basis. So in summary, I hope to have showed you that CT angiography can be and is being increasingly incorporated into the diagnostic algorithm of these patients with acute, mostly lower intestinal bleedings. It does have CT angiography a very high sensitivity for bleeds of moderate intensity, clearly a growing availability of the appropriate equipment in all of our emergency rooms, definite logistical and diagnostic advantages over angiography, endoscopy, and especially over scintigraphy. And in terms of technique, do remember that we need to acquire three phases. Thank you very much.
All right, thank you very much. We have about 5 more minutes. I would ask maybe Ian and also Dennis to come up to the podium close to the microphone. We have just a few questions also from our, actually not the virtual audience. I think it's the audience is real, but the virtual presence of the audience who are watching that course. So just very quick questions here. Maybe you can give quick answers. There's one question from Paul Kelly, which to Ian. The question is, Ian, do you use water oral contrast in clinical acute situation given potential delay? Maybe I ask a second question right here. Becomes the same. Can you use Doppler ultrasound in mesenteric ischemia?
So regarding the first question, yes, we usually do give water as long as the person is able to tolerate it. Some people are so sick that there is an aspiration concern, in which case we'll just forego it. We do not wait a significant amount of time, though, so we give the water and then generally get the patient in, so you just accept the fact that you're not going to get much distension beyond the more proximal part of the bowel. As far as the second question, yes, there is a potential role for Doppler ultrasound. So, for example, if there's a specific question about venous thrombosis or arterial thrombosis, and for whatever reason CT and MRI are not options for you, then you can definitely try that. It is often very technically challenging in the patients who actually really have problems because there's often a lot of bowel gas, so it's not easy. And so our preference would always be to try CT first, then MRI, and then ultrasound would be our last resort, but it certainly is an option.
The comment, Dennis?
And I just make one additional comment. I've actually seen portal venous gas on ultrasound, which is quite an interesting phenomenon when you see it.
Oh, wow. That's impressive. Okay. The quick question, I think you answered it already, but the one question is, do you advise non-contrast and arterial and venous phase for all suspected GI bleeds?
Correct, and I showed it with the last few slides why the 3 phases are necessary. Each one plays a different role. So if you're going to use this technique for these patients, you have to have the three series.
One question for Dennis, that is, can you explain exactly how to determine the neck of an aneurysm?
Well, are we referring to the abdominal aortic aneurysms or other aneurysms? Basically, there's an acute, relatively acute change in vessel diameter and contour as you come from the neck of the aortic aneurysm to the aneurysm itself. Can there be disagreement between individuals as to exactly where the cut point is? And the answer is yes. It's much easier when you have a saccular aneurysm, of course, with a neck adjacent to a vessel, either the aorta or a visceral branch.
Okay. Well, there's a final question, which I guess is directed to myself, which is how do you differentiate between true and false lumen on CT? And then the answer to that would be that it's if you have the entire aorta imaged and you see where the primary intimal tears, where the blood goes in and becomes a true and the false lumen, it's very straightforward. Let's say if you only had an abdominal CT in a patient where you didn't know it was a dissection and you have a dissection membrane there and you don't see the primary intimal tear, then the trick that I use is usually that the true lumen is usually made circumferentially out of elastic tissue, because the membrane that's a dissection flap is in fact consists of media, so it's elastic. So whatever the lumen is, it's usually round or behaves like a rubber band or contracts. That's usually the true lumen. So that's, I think, one of the best clues that I ever came up, and that, whenever you compare it then to a gold standard like the inflow or the primary intimal tear, that I really think works very, very, very well. Then a final question to just everybody. We have just 1 more minute, and the question is, we are seeing more emergency CTs being requested for acute endovascular repair on the type of unstable patient that used to go directly to the OR. Are you seeing this change too, or who is seeing this change too? Raise your hand. Everybody. All right. All right. Then with this, I thank all the speakers for their presentation, and the audience, and also the online audience to hang out with us. Thank you.